Thank you. So I'm going to try to give you a tour de force of some of the exciting, active new clinical trials, meaning clinical trials that are ongoing. I'm happy to answer questions afterwards about results of the everolimus and sunitinib data, but I'm not going to focus on studies that have been completed. I think also, just to preface this conversation, that as George said, there are a lot of very exciting, numerous clinical trials in this disease, both for carcinoid tumors and pancreatic neuroendocrine tumors. And I think that's incredibly exciting. And I think that the upcoming years will really will have more results on and answers about some of these newer agents. So I'm going to start with some disclosures. So just to share that for a lot of scientific talks, we have to give disclosures about relationships we may have with pharmaceutical companies. So my most recent disclosure is that I have a 3-week-old baby at home, and then I am a little sleep deprived and have not had on real clothes in about 3 weeks. So, but this is baby Austin. So I thank George for covering my patients and my patients who are here for waiting for me until I come back. And my other disclosure are my wild 6- and 3-year-old boys who are helping take care of their baby brother. So anyway, so I'll focus on, as I'd mentioned, talking about active clinical trials. I'll mention the trials that are open both at UCSF and at Stanford. I'm going to talk some about cooperative group studies, and I'll define that in a bit, but they're basically large collections of institutions that come together to build and develop clinical trials, which for rare disease is actually a very effective way of determining priorities for clinical trials and then accruing for a rare disease. And then we'll talk about some clinical trials that are in development. So up at UCSF currently, they have at their institution, and I should say that some clinical trials are open maybe just at a single institution and would require that you go there in order to get that care. So this is one of those. It's just open at UCSF. It's what we would call an investigator-initiated clinical trial where they developed the concept, so Dr. Bergsland and her team. This is a trial that uses everolimus or Afinitor or RAD001. It has 3 different names. Afinitor is the brand name, plus another oral agent called erlotinib that targets a different tumor growth pathway. So this is the concept of using 2 different biologic agents that target 2 different tumor growth pathways to see if it's effective in treating patients with neuroendocrine tumors. In my slides, the way I've arranged them is by sharing with you some of the eligibility and whether it's a phase 2 or 3 study, and then what the treatment is. Additionally, I've added at the bottom, and you should have this in your booklet, who the clinical research coordinator is at that institution. With their permission, I've added this. And so if you have questions specifically, I had some out in the lobby when we were looking at posters about eligibility for certain clinical trials, because not everybody is going to be eligible. It may depend on what tumor type you have or on what prior treatments you've had. So specific questions could certainly be addressed by me or George or by the trial coordinators themselves. So this is a phase 2 study, a small study of 44 patients. This is only open to patients with pancreatic neuroendocrine tumors. Disease progression is required in order to get on the study, and it's a combination of those 2 pills, and all patients get the pills. There is no randomization for this one. So at Stanford, and I've qualified this by saying these are almost active as we hope to be opening these in October. 2 studies, both of which had posters, so I've also put yellow stars on the trials that have posters outside, so we'll have a little bit more time to look at posters after this session. So if you have other questions, some of the folks who are involved in these trials will be standing by their posters and they'll have more information. So we are opening a study with pasritamig in patients with neuroendocrine tumors. This, as Dr. Bergsland mentioned earlier, is an octreotide or somatostatin analog. We're trying to learn more about how this agent slows the progression or may lead to tumor shrinkage in patients with both metastatic pancreatic neuroendocrine tumors and carcinoid tumors. It's a study that was initiated by Moffitt Cancer Center in Tampa, Florida. We collaborate a lot with them as they also have an extensive interest in neuroendocrine tumors, and it will be open at Moffitt, Stanford, and at UCSF. So that's called a multi-site study, but was initiated by the investigators. And patients will receive a pasritamig injection repeated every 4 weeks. This is another study that George and I have developed, and it uses capecitabine or Xeloda, many of you here have been on that, with temozolomide and Avastin. So capecitabine and temozolomide combined are now widely considered to be two of the more active chemotherapies in pancreatic neuroendocrine tumors, and they're both pills. And so there's a lot of interest in incorporating these two agents in future clinical trials. This is one, and I'll mention another one that's going to be a big national study. As we talked, it sounds like was discussed earlier this morning, neuroendocrine tumors are very vascular, so agents like bevacizumab, which are anti-angiogenic, are of a lot of interest in this disease. We've done other studies using bevacizumab, or Avastin as its brand name. We've used that in treating neuroendocrine tumors in the past and are optimistic about using this in other studies. So this will be a small phase 2 study. We also plan to open this at UCSF and at Moffitt, where we will hope to enroll 30 patients. All patients will receive the treatment, so it's, again, not a randomized study. Maria was around, she wants to, I'll make you stand, you can wave to everybody, but is one of our research coordinators in the GI oncology group and has been helping me and George, and she's one of the point people for this particular clinical trial. Another study that we have open is an industry-sponsored study. So in comparison to an investigator-sponsored study where George or I may come up with an idea, an industry-sponsored study may be a company that comes up with an idea and then sort of farms it out to academic institutions who can help enroll patients. And this is a study of lanreotide autogel for carcinoid syndrome. Specifically, it's not looking at how it affects tumor growth, but specifically how it controls the symptoms of flushing and diarrhea. And this is a randomized study, and patients are randomized to either receive the lanreotide itself or a placebo. Pardon? Yes, thank you for mentioning that, with crossover, as George had mentioned. And so it allows patients who are on the placebo arm, once that's determined, to then cross over to lanreotide should they need that for symptom relief. So cooperative group trials, as I mentioned, is another flavor of a clinical trial. So at Stanford, we are members of what's called the Eastern Cooperative Oncology Group, even though we're in the West. And George, I don't know, it's a long story, yeah. So we participate in clinical trials with other institutions who are members of this cooperative group. We meet twice a year to help determine priorities for clinical trials. And what's great is that if a trial opens within this cooperative group, it's open at many institutions. The cooperative group system is something that was first started I think in the 1950s by the National Cancer Institute, and there are a number of cooperative groups. And as I'd mentioned before, it's a really great way, in particular, for accruing to trials for rare diseases. So there are 2 ongoing studies that are open. This SWOG is the name of another group. It's the Southwestern Oncology Group, where they have a study for advanced carcinoid looking at interferon versus Avastin in both arms. It's a randomized study, and both arms also include octreotide. And then another cooperative group, UCSF and Dr. Bergslund's group, are part of the I forget what CLGB stands for, Cancer and Leukemia Group B, I think is what it stands for. This is a fairly new study that's for pancreatic neuroendocrine tumors, building on some of the information that we've just recently learned with everolimus. It's looking at everolimus versus everolimus plus Avastin. So again, does adding 2 biologics, is that better? Interestingly, what we learned in treating colon cancer is that adding to biologics is not better. Colon cancer looked at adding, using bevacizumab plus medicines that target a different growth pathway called the EGFR pathway, and we learned that those are indeed not better. So it'll be interesting to see what this shows. Fairly newly opened, and this is open both at Stanford and at UCSF. I want to talk a little bit about how clinical trials get developed. So, and I'll spend a couple of slides talking about new trials and ones that are currently in development. So George and I are both members of something called the Neuroendocrine Task Force. That's a group of physicians with representatives from all of the cooperative groups that come together and help determine priorities. What's important? What do we need to ask for patients with neuroendocrine tumors? And as Dr. Bergslund mentioned earlier, unfortunately, because it's a rare disease, we can't ask 100 questions all at once. We really have to focus and determine what our priorities are. We work with the cooperative groups, so trials have to be supported both by the task force and by the cooperative group, and then there's collaboration with the individual cancer centers. And about 2 years ago, in 2009, there was a clinical trials planning meeting for building trials with neuroendocrine tumors and helping to determine how we want to build trials. George went over a number of those features, but 10 years ago, when we were building trials for this disease, we kind of lumped everything together, and we have now since learned that that actually gave us very little useful information, because we now know carcinoid tumors behave very differently than pancreatic neuroendocrine tumors. We've also learned that we need to be very specific about the grade of tumor in terms of who's eligible and in what prior treatments patients have had. So now I think we're building much better clinical trials, and we'll be able to get more useful information out of them. So these are a couple of clinical trials in development. The first is one that I'm spearheading that is looking at chemotherapy in pancreatic neuroendocrine tumors. So what we know, so sunitinib and everolimus have recently been approved, but those are biologic medicines. Chemotherapy may have a role in some patients, particularly in patients who have very bulky disease, fast-growing disease, or who have symptoms from their disease. And interestingly, as George said, we don't have a chemotherapy that's been approved since 1972, and that was streptozocin. And so we'd like, with the development and use now, some in the community, of temozolomide and capecitabine, we'd like to know, is temozolomide the active agent, or are both together in fact better? So we're building and designing a clinical trial that will be randomized with one group of patients receiving temozolomide and another group receiving the combination. This is an exciting trial, actually, another one that I'll be involved in that's being spearheaded by a surgeon from Albert Einstein, I believe. And this is a study for patients with metastatic pancreatic neuroendocrine tumors who have liver metastatic disease, who've had a surgery to remove all visible disease, and then we propose to give half of the patients everolimus, and then half will get placebo. So this is that question of, can we do something to help patients after they've had a surgery? Can we help prolong their disease-free interval? Can this help cure patients who've had metastatic disease? So I think this is a very exciting question, hopefully one that could then potentially be implemented for patients who've had just a regular, sort of limited or localized pancreatic neuroendocrine tumor, and that's probably a future question. Lastly, Dr. Bergslund is spearheading a trial for carcinoid patients. So patients with carcinoid tumors also had a big phase 3 trial completed using sunitinib. It has not yet been FDA approved for that disease, although many of us in the neuroendocrine community feel that this is an active agent. But I think the next set of trials will be looking at some of these other biologic agents. So pazopanib, so anything that ends in an IB, is considered a tyrosine kinase inhibitor, and that's another biologic medicine that would target a tumor growth pathway. This one specifically is also involved in an anti-angiogenesis pathway similar to Avastin. And this would be pazopanib versus placebo for patients with advanced carcinoid tumors. Lastly, There is a poster outside. Dr. Iagaru and Dr. Moski they are helping us develop this trial and bring it to Stanford. So of PRRT, peptide receptor radionuclide therapy. I mentioned it earlier, but it's a trial that would be randomizing patients to PRRT versus octreotide. And I'd encourage you to talk to them and look at the poster. We hope to have this open in 2012, but there are a lot of hoops to jump through in order to get this open in the United States, but this is what's been available in Europe for some time. So I think that the take-home points for the clinical trials today are that we have really a lot of exciting trials ongoing in this disease and new ones that are being developed. I think that what's important for you also to know is that those of us involved in neuroendocrine research really collaborate quite a bit to come up with priorities for asking questions about the next best question in treating patients with neuroendocrine tumors. I know that a lot of the clinical trial patients have been recognized with their special badges today, but I'd really like to thank all of you who have participated in clinical trials, because without you, we could not advance the field. I'm happy to take questions, and I'm sure George would be happy to take questions too. So, thanks.